Well, thank you for inviting me to talk today. I'm very pleased to be able to give an update on COVID and HIV, but also to have the opportunity to look at this through a more statistical lens, focusing on some of the challenges that we're now facing when attempting to assess the impact of HIV on COVID outcomes. So here are my conflicts to start. Now, I don't need to tell anyone here about the devastating global impact of SARS-CoV-2. I think it's fair to say that just over a year ago, when the first reports of the virus started to appear, none of us had a clear understanding of whether HIV would have an impact on either the risk of infection with SARS or its outcomes. And yet, despite this complete lack of evidence, there was a really urgent need for guidance on how to support people living with HIV, particularly around recommendations for shielding, and more recently, of course, around guidance for vaccination. Over the past year, we have been inundated with reports about COVID and its outcomes, with many people feeling immense pressure to report their observations and experiences. Academic journals have introduced fast-track review processes for COVID submissions, and manuscript preprints, few of which have been through any formal peer review, have been circulated widely. And in some cases, I really think this has actually hindered rather than supported our progress. So today what I want to do is to start by summarising some of the key studies that have attempted to describe the outcomes of people with HIV and COVID. It's not going to be an exhaustive review. I simply just don't have the time to do that. But I want to focus on a few of the larger studies, using these to illustrate some of the methodological challenges that we're facing when we conduct and interpret these studies. So I want to start by thanking Laura Waters for this slide. This was pretty much the state of play last October when Laura presented the slide at the HIV Glasgow meeting. Now, she did go on to describe a few more studies in detail, which I'll also do. But the whole point really was that this was only 5 to 6 months ago. And at that point, we really have very limited information about the possible interaction between HIV and COVID. And as you can see from this table, many of these studies were extremely small, often without any controls and from limited geographical settings. Now, there have been some other studies. Spanish investigators have collected data on all confirmed COVID-19 diagnoses among people with HIV on ART over the period from February to mid-April. And they reported that overall age and sex standardized risk of COVID diagnosis among people with HIV over that 75-day period was 30 per 10,000 population. And there was COVID admission and ICU admission rates of 17.8 and 2.5 per 10,000, with a COVID death rate of 3.7 per 10,000. Now, to put that into context, the authors then reported that the equivalent risk of diagnosis in the Spanish general population was 41.7 per 10,000, but this was actually reduced to 33 when they excluded healthcare workers from that calculation. And the mortality rate in the general population was 2.1 per 10,000. So you can already see now a mortality rate that was around 80% higher than in those with HIV, sorry. Now, in the UK, we'd also been looking at COVID-19 outcomes, firstly through an analysis of the ISRIC data set, which included over 47,000 adults hospitalised with COVID, 122 of whom were HIV positive. In this analysis, we considered the 28-day mortality as the primary outcome. There were several key differences in the characteristics of people with HIV who'd been admitted with COVID and the rest of the population, most notably here in terms of the age. And you can see that people with HIV were 20 years younger on average than those without HIV. And perhaps more importantly, if you look in the age group who over 60 there, you can see that's around a third of those with HIV. But in the HIV negative group, that was around 3/4. And as we would expect, given what we know about the population of people with HIV in the UK, there are also differences in that the people with HIV were less likely to be women, but more likely to be from Black or other ethnic minority groups. Now, there were also differences in the comorbidity history of the participants here, with lower rates of cardiac disease, pulmonary disease, dementia, and malignancy in those with HIV. And this actually might seem surprising because we know that HIV infection is associated with an increased risk of these comorbidities. But of course, we have to take into consideration that 20-year age difference between the two groups. And I think that's an important point, that when we think about confounding factors, sometimes that confounding may be hidden by other differences in the populations. Now, this slide shows the Kaplan-Meier curves for mortality in the two groups at the top. So just to orientate you to this, the blue line here is the HIV negative group. The red line is the HIV positive group. And the fact that the blue line is lower indicates that people without HIV, so the general population, actually had a worse mortality risk than people without HIV, with HIV. And if we found the same pattern then when we stratified by sex. But when we stratified by age group, we started to see some very different pictures emerging, particularly in the younger age groups here. So those under 50 and those aged 50 to 59. And you can see in both of those figures that the red line is now below the blue line, suggesting that in people under the age of 60, those with HIV have a worse mortality outcome than those without. In the older age group, however, the lines were pretty much the same. And remember that this is the biggest group. It makes up the majority of that full population. And that's why overall we see this effect here. So this is really a very nice example of Simpson's paradox. Now, this was reflected in the results from the Cox model, which showed that without adjustment, there was no significant difference in the 28-day mortality between those with and without HIV. And when we adjusted for sex or ethnicity, this really didn't change those findings. But as soon as age was introduced into the model, you can see that that effect was reversed, indicating a higher mortality rate in those with HIV when compared to an HIV negative group of a similar age. And then at this point, adjusting for other factors in the model actually really had very little impact on that estimate. Now, there was a second large analysis of COVID outcomes being undertaken in the UK, and this was from the Open Safely group. This is a data analytics platform which routinely collects data from a subset of primary care practices, and that was then linked to national death registration data. Now, importantly for this analysis, all included adults have been registered with a GP for at least a year prior to the date. The outcome was COVID death, as identified through the death registration form, and HIV status was identified through GP records. Now, the benefit of this approach is it provides a huge population-based denominator with almost 18 million records in the analysis, of whom just over 28,000 were identified as being HIV positive. And to put that into context for those who aren't in the UK, this is around a quarter of those known to be living with HIV in the UK. But the results from this analysis were actually pretty similar to the ISARIC analysis, with no significant association overall, but then a negative association with HIV emerging after age and sex were included in the model. And this association remains similar in most subgroups. Now, in contrast to the ISARIC analysis, they did find a stronger association here in the Black group. And they also found that the analysis was restricted really to those with at least one comorbidity. And I'll come back to this later. Now, the real benefit of this analysis is clearly the size of the data set that can be analysed, but the major limitation is that the authors are dependent on accurate information on both HIV status and comorbidities in GP records. And this actually can be problematic, particularly in the UK. And of course, neither this nor the ISARIC analysis was able to control for any key confounders, including occupation, which is clearly an important risk for exposure, or measure of HIV disease stage. Now, not all studies have found such an obvious association with HIV. This is an analysis of a large network in the US, which included over 50,000 people with COVID, of whom just over 400 had HIV infection. In unadjusted analysis, those living with HIV had a mortality rate, a 30-day mortality risk that was 55% higher than those with HIV, and there was an 83% increased risk of being hospitalized. Now, rather than using a standard multivariable regression, the authors here used a propensity score matching approach, which is another approach. It gives you similar results, and it also attempts to reduce the impact of potential confounding. Now, what they found was, but when they matched in this way, that both of those assessments were attenuated. The inpatient association remained significant, but the mortality association was no longer significant. But I just want to point out that because this is now a matching process, of course, with each person with HIV matched to each control without HIV, the numbers in that HIV negative group have really dropped dramatically, and hence the confidence intervals here are pretty wide. And so, personally, I think this still does suggest that there is an association there, but of course, with those wide confidence intervals. Now, the final data set I'm going to show is from the Western Cape province in South Africa, another extremely large data set containing records on around 7 million people, of whom 500,000 had HIV infection. Among the full population in the data set, those with HIV had over a twofold risk of COVID death compared to those without HIV. But interestingly, they found very similar associations regardless of immunosuppression or viral suppression. So, is there any consistency between the studies, and if so, why? Well, firstly, I think it's worth pointing out that overall the studies that have reported associations have tended to be the larger ones and those reporting more recently. And clearly HIV is a relatively rare infection in many settings, particularly in Northern America and in Europe. And therefore studies do need to be of a sufficient size to be able to detect an association. Now, I would urge you to read one of the several excellent commentaries that have been written on the topic, including a review of the open safety study from Laura Waters and Anton Posniak in the Lancet HIV. And there's also a commentary from Jeannie Triont in Clinical Infectious Diseases. And both of them discuss some of the limitations of the different analyses that have been published. But beyond this, I think there are several analytical challenges that we really have to consider. And I've grouped these into those which relate to selection bias, so essentially the definition of the population that's included, those that relate to confounder adjustment, particularly in terms of which confounders we should adjust for. And then finally, just briefly, I want to talk about the perils associated with the use of big data. And I've alluded to some of those already. So let me start by thinking about the populations that are included in the different studies. You will have noticed from the studies that I've described so far that they've all included different populations of people, ranging from the general population, as in the Western Cape study, say, those who are registered with a GP, as in the open safety study, those who are hospitalized with COVID, as in the ISRIC analysis. But the studies also differ in terms of how COVID itself is defined and whether it's based on a positive test for SARS or a clinical event. So it's probably not that surprising, therefore, that findings may be inconsistent. Now, you could argue that if you're investigating the association with HIV status, then this shouldn't matter too much, as long as the approaches used have been used consistently between those who are HIV positive and those who are HIV negative in the study. But of course, this may not always be the case. And I want to illustrate this visually. So imagine we start with a group of people here with HIV, and of these, a certain proportion of those will have SARS-CoV-2 infection. Now, there'll also be a proportion of that population who have symptoms that are suggestive of COVID, but those two groups are not going to overlap completely. There will be some people here who are asymptomatic, and there will be some people here who either really didn't have SARS-CoV-2 because maybe they had flu or another viral infection, or perhaps they had a false negative test at the time. Now, on top of that, some of these people would be hospitalized and some of these people would be admitted to ICU. And for simplicity, I'm going to assume that this will only be amongst the group who are symptomatic. Now, this is all fine. This is what we would expect for any viral infection, I think. But the difficulty arises because some people may drop out along those pathways. And so, for example, you may get people who die without being admitted, and you may have people here who die without being tested. And those people will not, therefore, appear consistently in different analyses. And so your populations may differ. Now, of course, if the chance of this happening is independent of HIV status, then comparisons with the general population shouldn't be biased. But if the threshold to test someone, to admit them to hospital, or to admit them to ICU is affected by knowledge of their HIV status, then we start to introduce bias. And in fact, there were some interesting data presented at the recent virtual CROI meeting, which suggested that there were different thresholds here, particularly for testing people. And of course, it would help if we knew the proportions in some of these groups, but of course we don't. Tests have improved in sensitivity and the recommendations for testing have changed. And so the proportions and types of people who are tested may well differ, depending on when you're considering those hospitalized last March, say, compared to those hospitalised now. And I mean, just imagine if you look in the UK, our testing has really changed, so that initially it was only people with symptoms who were tested, whereas now anybody can have a test. In the Cape in South Africa, that was completely the opposite, in that testing over time actually was reduced. So you can see that different studies have very different testing patterns. And this then leads me on to the problems of dark data, which sounds like something that statisticians would collect through forays into the dark web. But in fact, here, what I'm referring to is a term that's often used in marketing or information fields to describe information that's routinely collected by organizations, which could provide really important information, but which is never used for any purpose. So essentially, it's data that's fallen down a black hole somewhere. But the term has recently been adopted by some statisticians to refer more generally to data that's relating to hidden populations that we never see, but without which our conclusions may be invalid. And just as an example, we know that a person has to be exposed to SARS-CoV-2 before he or she can be infected, but exposure is modified by advice to shield or to self-isolate. And of course, in many settings, those with HIV, particularly those with low CD4 counts, were generally advised to shield. And so we wouldn't expect to see that many people with low CD4 counts acquiring COVID. And if a study therefore reports no association of a poor outcome with a low CD4 count, then do we really believe that this is the case, or does this simply reflect the fact that there are very few people with low CD4 counts who made it into the analysis data set? So what about confounder adjustment? Can we and should we? Well, just as a reminder, when we're investigating any association here between HIV and a poor outcome, be that COVID infection, morbidity, or death, we always have to consider whether there may be factors which may confound the associations we see. And what this would mean is that the association we witness here may not reflect the true causal association between HIV and the outcome, but may also reflect some of the association with the confounder. So let's start with age. Should we adjust for it? Well, I think that's fairly straightforward. Yes, we should, but it's surprising how often even this simple adjustment doesn't happen. And just as proof, here's a recent meta-analysis that looked at the role of several concurrent infections, including HIV, on the clinical outcomes of COVID. And this is the figure from the paper for the HIV analysis with some of the studies that I've just described here. And if you look, for example, here's the Giretti, this is the ISARIC analysis, this is the unadjusted estimate here. The HADI analysis I also reported, that's the unadjusted estimate. So the main conclusion of this analysis was that the clinical outcomes of COVID in those with HIV were comparable to those without HIV. That's clearly very misleading, and I think it's a potentially dangerous conclusion for people with HIV. Now, what about adjusting for gender? Well, again, this is probably straightforward to do and should be adjusted for. What about ethnicity? Well, this is where things start to get a little more difficult. Not only may this not be possible in some countries, particularly where collection of data on ethnicity is prohibited, but we must also recognise that ethnicity is almost certainly a proxy for differences in other things, so socioeconomic factors, say occupation, income. And therefore, when we interpret any findings around this, we really have to remember that this isn't a biological construct, but it also captures some of those socioeconomic factors. Occupation, well, strictly occupation may not be a confounder, but it is important and it does play a role. But this is a really difficult factor to capture because most large studies would struggle with the collection of data on occupation. And it may also be something that people with HIV may be a little bit more cautious about sharing. So occupation is a difficult one. And then finally, what about comorbidities? Well, this of all of them is probably the more challenging, not only because of the difficulties in collecting unbiased data on these, but also because some of these comorbidities may actually lie on that causal pathway between HIV and a poor outcome. And so rather than this picture here, what we may actually see is something like this, where HIV increases the risk of comorbidities, and then that in itself leads to a poor outcome. So in this case, if we adjust for those comorbidities, we actually reduce some of the association we see, and our estimate will be an underestimate of the impact of HIV infection. And just on this topic, I obviously haven't presented much from CROI today, but there was a presentation from the US National COVID Cohort Collaborative, which was of relevance, I think. And this was an analysis of almost 3,000 people with HIV, 4,600 solid organ transplant recipients, and around 500,000 people without either, all of whom were hospitalized with COVID in the US. Now, when the authors compared the outcomes of those with HIV to the non-HIV, non-transplantation group, those with HIV were over twice as likely to be hospitalized here as those without HIV. And this estimate dropped after they adjusted for demographic factors, but they then adjusted further for comorbidities, and that dropped even further. And their conclusion was the increased risk was driven in large part by the high burden of comorbidities. Now, interestingly, when the abstract was submitted, if you check back to the abstract, it had around half the sample size in this analysis. That odds ratio had actually attenuated completely to 1. And the authors had initially concluded that the increased risk was fully driven by comorbidities. So I think there's an important lesson there that we really have to be quite cautious about interpreting findings that when we only see a small or selected portion of the data. Now, finally, what about the perils of big data? Well, I've alluded to some of these already in relation to the Open Safely dataset, but I think it's worth reiterating some of these, particularly when the analysis requires access to sensitive data, which may not always be available. So, for example, in the UK, we know that most people with HIV are registered with a GP, but a substantial number of people haven't disclosed their HIV status. And those that have will tend to be those where there is perceived to be a genuine need for the GP to know that. So, for example, where there's serious comorbidities that are present, or where there may be a concern about drug-drug interactions with prescribed medications. Now, whilst the incorrect inclusion of, say, 1,000 people with HIV into a data set of 17 million apparently HIV negative people is not going to change the effect in that group, if you move those 1,000 people into the HIV positive group where they should be, that really is going to change the associations. So there is a potential here for misclassification to result in bias. So to summarize, overall, do I think that HIV is associated with poorer COVID outcomes? Probably yes. Do I think the poorer outcomes are directly due to HIV infection? Probably not. It may simply be that HIV is a marker for a group of people that, on average, has many other risk factors for infection or poor outcomes. The literature, unfortunately, hasn't been helped by the inclusion of many studies that are clearly small and underpowered, and where the analyses have not been appropriately conducted. But I do think this is really important because this has a huge impact on the way that people with HIV are managed clinically and the advice that we give them. Now, if we look to the future, I think we're going to have challenges in terms of our analyses. And there's 2 areas where I think we're going to experience particular challenges. Firstly, when we think about the long-term outcomes of COVID in people with HIV, particularly when many of the reported symptoms of long COVID actually overlap very much with the reported symptoms in aging cohorts of people with HIV. And secondly, of course, when we think about the impact of COVID itself or health systems' responses to this on HIV outcomes, both of those I think are going to be really difficult studies, subjects to study robustly. So I want to stop there and thank you for listening. I'm going to end with a picture of our lovely English countryside from Kew Gardens, really to remind us all that, despite all the awfulness of the last year, there have been an awful lot of positive things in the world, and many of us have had the first time really to explore some of the things we don't normally see on our own doorstep. So thank you very much for listening.